Hello, everyone. Welcome to this special presentation, Telehealth and Continuity, Strategies for PTs, OTs, and SLPs During Crisis. This is officially our largest webinar ever. We're talking over 13,000 people registered, and we just announced this presentation last week. That demonstrates how crucial this topic is at such an unprecedented time in our lives. We thank you all so much for joining us today. Thank you to everybody who is in our webinar platform right now, and also a big hello to everybody on Facebook Live viewing this streaming event. I am your host, Charlotte Bonet, WebPT's Senior Director of Demand Gen. And before I hand things over to our incredible hosts, I'm going to cover a few housekeeping items. This webinar will last an hour and a half, roughly. We're going to do about 60 minutes of presentation, and then we're going to allow 30 minutes of Q&A. If you have a question during the webinar, go ahead and ask it in the side panel. For people on Facebook Live, you can go ahead and comment your questions. We'll do our best to answer as many questions as possible, but please understand there are going to be thousands upon thousands of questions probably coming in, and we have 30 minutes for Q&A. So we're going to do our best to moderate all the questions and answer the most frequently asked ones or the most common ones. And whatever we don't get to, we're going to comb over all of them to again pull out more common ones and put together an FAQ blog post to share with everybody in a few days. We're also, by this afternoon, going to email this recording and slide deck to everyone. And we're constantly updating the blog. So I understand everybody's got lots of questions, and we're going to do our best to answer as many as possible. I also want to emphasize that with this particular topic, policies, guidelines, and best practices are changing really fast, basically by the hour some days. So while we have done and will continue to do our absolute best to bring you the most accurate, up-to-date information possible, understand that we are not the end-all, be-all authority, and the information presented here could change in the future. That's why we always recommend verifying all billing and regulatory information with the appropriate source, whether that's your payer, the state government, or board, or even CMS. So with all of that, I'm going to kick it over to Heidi.
Hello, everyone. I'm Dr. Heidi Janenga, and I'm a physical therapist with a little more than 15 years of experience practicing in sports medicine and orthopedic private practice. Now, I'm also the co-founder and chief clinical officer of WebPT, which is a web-based software platform for PTs, OTs, and speech-language pathologists. My co-founder and I started this company back in 2008 because there wasn't a documentation solution available at the time that truly suited my needs as a physical therapist and clinic director. And since then, we've grown to more than 85,000 members, over 15,000 practices across the U.S. And we here at WebPT host these free webinars because one of our goals as a company is to help rehab therapists achieve greatness in practice. And I truly believe that starts with education, especially now during these unprecedented times. Today, I am thrilled to be joined by John Wallace, WebPT's Chief Business Development Officer of Revenue Cycle Management, and Vita Colmer, who's also an OT, and WebPT's Chief Compliance Officer. We have a lot of business and compliance information to cover today, so who better to help us unpack it than these two incredible experts? Thank you so much for being here today, and welcome to everyone.
Thanks very much, Heidi.
Yes, thank you, Heidi. Happy to be here.
All right, everyone. Well, let's jump right into it. Over the past several weeks, we've witnessed an unprecedented turn of events. On March 11th, the World Health Organization declared the outbreak of the COVID-19 coronavirus a major pandemic. And while the U.S. has had its share of catastrophic events in recent memory, from the wildfires in California to the hurricanes in the Southeast, we haven't seen an event this widespread and devastating in decades. As a result, many rehab therapy practice owners have been left scrambling for solutions to carry them through this critical moment. Amid this crisis, recent legislative changes to expand the use of telehealth have opened doors for rehab therapists that have been shut and locked for some time. Of course, federal policy, or even state and payer policy for that matter, is rarely cut and dry. which is why John, Vita, and I are here to help you navigate the virtual care waters and provide you with other strategies to help you maintain business continuity. So let's jump right in. The coronavirus outbreak has shined a massive spotlight on the need for expedient crisis response, for sure at the government level, but also at the community level, in organizations and businesses, and even for individual citizens. As healthcare providers, we have a unique opportunity and responsibility to serve and protect our patients, our staff members, and of course ourselves. With that in mind, emergency preparedness and business continuity plans are absolutely essential for them and for us. After all, we still need to be functioning when this is all said and done. With that in mind, here are 4 essential things to consider at this very moment.
The health and safety of your staff and patients is of the utmost importance, always in ordinary times, but especially now in the midst of a contagious disease outbreak. Your very first priority must be implementing practices to keep your staff and patients healthy. As a hands-on healthcare provider, this becomes mission critical for you right now because the virus is spread through airborne droplets, and those droplets are more easily transferred through close personal contact. Fortunately, though, you are well trained in universal precautions and infection control when interacting with bodily fluids. Please continue to adhere to these principles and ensure your staff do so as well by disinfecting equipment routinely throughout the day, and especially after treatment sessions, properly utilizing personal protective equipment. And I know that personal protective equipment is very scarce right now, so if you don't have this, adapting your sessions to reduce close personal contact and frequently washing your hands. And if you don't have soap and water available, using alcohol to clean your hands. If you provide care in the home setting, limit the equipment and personal items that you bring into the home and disinfect that equipment before returning it to your vehicle. If you're wearing gloves, remember to dispose of them immediately after vacating the home. Disinfectant wipes, the ones that we've been using over the counter for years, are very effective in reducing the spread of infection, so you can use those to clean your equipment. And remember that we are ultimately responsible as healthcare providers for doing no harm and ensuring our patients can benefit from the therapy they receive without undue risk of harm. If you have personal protective equipment and the ability to wash your hands, and your patient can participate safely in the therapy without exposing others, then you may treat the patient as long as you are legally able to do so. But use your judgment. In some situations, you may have no choice but to request that patients who do not feel well in the past 2 weeks or are currently experiencing symptoms receive their treatment via home health or telehealth. And keep in mind that many states like Massachusetts, Illinois, and soon to be Arizona are issuing executive orders for providers to adopt telehealth and for payers to cover those services. Some are also relaxing requirements around service delivery, particularly the platforms providers must use.
Now, we're not going to go into specific advice here regarding disease prevention and containment other than to direct you to the CDC guidelines for healthcare practitioners. There, you'll learn the exact measures you should be taking to minimize your risk. As for putting these action items into practice, though, your patients and staff will be looking to you to set the standard during the pandemic and beyond. With that in mind, I implore you to be the example. While there is no reason to panic, there is every reason to adhere to these guidelines by washing your hands well and often, and minimizing the chances of exposure for everyone. Now, the only surefire way to eliminate risk is to close your clinic to face-to-face visits completely, which, depending on the population you serve, may end up being the right move, at least temporarily. But this is always your choice at the end of the day. Some states are already demanding that all non-essential businesses close their doors. And while the U.S. Department of Homeland Security recently announced that PTs, OTs, and SLPs are included on its list of essential, critical infrastructure workers, it's ultimately up to state and local jurisdictions to decide who can and can't continue performing their job duties during this crisis. Most states have deemed all healthcare businesses as essential, but others like New Jersey and Pennsylvania are only allowing businesses deemed as life-sustaining to remain open, and PTs won't always fall under that designation. That said, some of you will need to remain open in order to reduce the musculoskeletal burden on primary care providers and hospitals. But back to what we can do in the day-to-day. Social distancing in terms that have been used heavily, a term that's been used heavily over the last few weeks, is really the absolute best thing that we can do to flatten the curve of this disease progression. If we can do that, and if we can slow its rate of transmission, then we stand a chance of ensuring that our medical systems can handle the number of patients who are forecasted to need these services over the next several months. Regardless of what your state and local governments have dictated, please start practicing social distancing now, in and out of your clinic. Even if COVID-19 virus is unlikely to cause detriment to your health and well-being, it's proving deadly to a very large and very vulnerable population. But I would like to make this point, despite how it may sound, the act of social distancing isn't necessarily just reducing the number of social interactions you have with other people. Social distancing also means putting physical distance between yourself and others, preferably 6 feet, which is why the World Health Organization has started to refer to this practice as physical distancing rather than social distancing. In any case, it's best practice to follow all social and physical distancing recommendations as strictly as possible. And to put just a caveat on this point, because we are practicing physical distancing doesn't mean that you have to and should close your clinic. This is just to decide on how to actually implement these practices, which we'll talk about later, within your practice to maintain your doors open to see those patients that are truly in need.
Yes, some practices are already being asked to implement social distancing at their clinics. Even if you haven't been officially asked yet, it is the best large-scale preventative measure we have at our disposal. That essentially means minimizing the staff and patient density in your facility by reducing the number of concurrent appointments, encouraging non-clinical personnel to work from home, keeping your patients and staff members at least 6 feet away from each other at all times. And anybody in therapy knows that can be challenging because we get up close and personal with our patients on a day-to-day basis. So I recommend having a conversation with your patient about what they feel comfortable with and adapting the session so that you can maintain that distance but still provide good quality care. Filtering your schedule to exclude the most vulnerable patients and therefore help shield them from exposure. For example, anyone who is frail and elderly, immuno or respiratory compromised, or has severe comorbidities such as diabetes and obesity. Preventing visitors from entering the clinic and asking patient family members to wait outside or in their cars as opposed to in the clinic waiting areas.
Now, these are unprecedented times, and we have to remember that during these times, there are going to be many decisions that are made as individuals, and we must remain cohesive as a community and respect others' decisions on whether they close their clinics or remain open. We have a unique responsibility. At this point in time, we've been deemed essential workers by the federal government. And we have the opportunity at this point to shine as frontline primary care providers, as physical therapists for our patients at this moment as well. This can be difficult to make this decision, especially for small businesses, when some employees may, if you decide to stay open, some employees may say that they don't feel safe. There must be policies put in place to make sure that everyone's decision during this time is respected. Now, this can be difficult, especially during these times when cash flow can be tight. However, it's absolutely imperative that your staff members stay home at the first sign of illness. Frankly, this is a good practice to implement even when we're not facing a pandemic of epic proportions. But right now, there is absolutely no question that employees who are feeling under the weather or believe they may have come in contact with the virus must, at a minimum, self-quarantine immediately. They may also need to seek out testing and medical attention. To make that happen, though, you as a business leader, as much as possible, establish supportive sick leave policies. That way, employees are able to rest, recover, and seek out their healthcare services they require without having to weigh that against being able to pay their bills. There has been word that the government is working on financial measures for small businesses that would help you support your staff in this way. But regardless of what ends up happening there, we really don't have a choice in the matter at this moment. The health and well-being of our country and the world outweighs just about anything else at this time.
Heidi, those are great practices, but they're difficult practices because a lot of businesses will face cash flow problems. However, luckily, the federal government is responding with economic stimulus packages and emergency relief. Under the Families First Coronavirus Response Act, companies with fewer than 500 employees are required to provide 2 weeks of paid leave, either with full pay at the employee's regular rate, to quarantine, seek a diagnosis, or obtain care for the virus, and that is capped at $511 per day. And at 2/3 the employee's regular rate to care for a family member for the same reasons, or to care for a child whose school is closed, or when a child care provider is unavailable due to the coronavirus, capped at $200 a day. Full-time employees are entitled to 80 hours of paid time, and part-time employees are entitled to paid time that is the equivalent to the atypical numbers of hours they work in a 2-week period. Additionally, under the Emergency Family and Medical Leave Expansion Act, companies with fewer than 500 employees must grant employees who have worked for the company for at least 30 days with additional job-protected leave to care for a child during school or child care closure. On a temporary basis, the employees may take 10 days of paid leave after the first 10 days of unpaid leave. This leave is paid at 2/3 of the employee's regular rate, capped at $200 per day, and $10,000 in aggregate per employee. Employees with fewer than 50 employees that can demonstrate that these stipulations would jeopardize the viability of the business may be able to apply to the Department of Labor for an exemption. Additionally, the Secretary of Labor has the authority to exclude certain healthcare providers and emergency responders from these provisions. This likely applies to staff in hospitals, nursing homes, and assisted living centers where not having providers available could jeopardize patient safety, but it would most likely apply to nursing staff. To offset these upfront costs, businesses will receive reimbursement in the form of 100% refundable government tax credits. And hot off the presses this morning, so I don't have a lot of details, there is a $2 trillion stimulus package working its way through Congress that will provide relief to businesses and individuals, so stay tuned.
Vita, thank you so much for all that great policy information. And for all of you listening, we'll recap all of it in the post-webinar FAQ blog that we'll send you later this week. And trust me when I say, on every single count, having an unwell employee stay home is better for you, your staff, your patients, and your business in the long term than having that person come in, even if it means rescheduling patients in the short term. And all of these policy references also should be maintained when it comes to patients if you are deciding to continue to have your clinic stay open. So making sure that you have policies in place to have questions and guardrails on what patients are able to come in to see your team in staff is important as well. Now, this is just another reason why having clear policies and procedure manuals that your staff understands and even your patients can understand when it comes to policies referencing them is important to your practice. In that way, when you need to make temporary or even urgent changes, you have a starting place to begin from. Now, engaging in clear communication with employees as these types of changes are made is essential for maintaining positive morale within your organization as well.
And if it comes to it, you are allowed to request an employee to go home and or seek medical attention if you suspect he or she may be exhibiting symptoms. In other words, it's your responsibility to keep your workplace as safe and healthy as absolutely possible.
So what do you do if a staff member either tests positive for COVID-19 or exhibits symptoms that go beyond the common cold or references that they have been in contact with someone who has tested positive? We've been getting this question a lot, so I think it's worth delving into. And for reference, the most common symptoms of the infection are fever and dry cough.
That's a great question, Heidi. The best practices here are straightforward. The first thing to do is review the employee's schedule with him or her to determine who that individual was in close proximity to, meaning within 6 feet, over the last 2 weeks. Then assist the employee with obtaining the medical support he or she needs as quickly as possible. Finally, send home every employee that the person came in contact with and get in touch with all patients who may have been exposed to inform them about the situation. It's most important to note that you cannot share identifiable information about the employee that was ill, as that would be a breach of workplace privacy laws. Instead, you could say something to the effect, I have reason to believe you have been in contact with someone who has either tested positive for COVID-19 or is exhibiting symptoms. While there is no cause for immediate alarm, you may need to self-quarantine while monitoring for symptoms per current CDC guidelines.
Again, we will be sure to share that script in the FAQ that will follow this webinar. So for all of you out there who are frantically taking notes right now, I implore you to just take a moment and just listen. We will be providing all of the documentation and notes from this webinar thoroughly as we move forward. So while most people will likely handle the news stoically when somebody tests positive, you may come across a person or two who will express fear or anger. So just stay calm and share that while your practice followed all CDC guidelines to a T, there is simply no way to completely eliminate the risk of this infection. Additionally, just because someone may have come in contact with the virus, it does not mean that that person will get sick. It simply means that health officials are advising additional precautions over the next few weeks to make sure that we curb the spread of the virus as much as possible. Let's move on to staffing issues. We know that there are developing across all industries right now, not only as more staff members either fall ill or decide to self-quarantine out of precaution, but also as municipalities push public orders of business and school closures, the latter meaning that parents must stay home with their children. If you're feeling the crunch of being short-staffed right now, you're not alone. However, from what we are seeing in our cancel no-show rate data, being short-staffed isn't really the issue at the moment.
If you find you don't have enough working therapists to support your patients, then it's time to reach out to the greater rehab therapy community, especially if your patients are those for whom rehab therapy support is crucial. After all, as therapists, PTs, OTs, and SLPs, our focus must always be on our patients.
That's right, Peter. I always like to use the example of Joplin, Missouri. In the aftermath of that 2011 tornado, providers from all disciplines came together to create a makeshift clinic to treat those who were hurt. And while this is basically an entirely different kind of national disaster, the sentiment remains the same. Reach out, connect with your community, and look for ways to band together and to support people.
Heidi, I love how you recently asked rehab therapists to think like primary care providers right now by asking two important questions. Are you ready and able to organize disaster relief efforts at scale? And are you prepared to diagnose patients and direct them to receive proper care? If the answer to either question is anything other than a confident yes, then when this situation is behind us, it might be time to take a look at the discrepancy between the roles we're currently occupying in the healthcare ecosystem and the roles we want to be occupying in the decade to come.
As more states shelter in place and close down all non-essential businesses, you probably won't see many patients for issues like low back pain over the next few weeks or even months. But you may be called on to support post-surgical rehabilitation and provide maintenance care to patients who would otherwise experience severe functional decline in the interim. Think about all those patients who actually are in pain. The worst thing that we can do is make a slide backwards on patients receiving pain medications just by going to urgent care or the ER to get them out of those locations to provide services to those who are most in need. And as I mentioned above, we can provide valuable support to help patients receive the treatment they need before they become emergent and require those hospital services, which, as we all know, are already being severely taxed.
That's a good point, Heidi. It would actually be better for patients to remain outside the hospital, which would reduce their exposure and free up resources for patients that have the virus. So our services are very critical in prevention and keeping patients healthy. Also, patients that are the most severe cases of COVID-19 are the elderly, and these patients really cannot afford to have prolonged periods of bed rest or to have severe respiratory problems. So they may require acute rehabilitative care to get back on their feet and to get back to life. And the better equipped we are to serve them and the less time that they spend in the hospital or in a rehab facility or by themselves at home, the better off they are.
Now, you'll also want to make it a point to keep an eye on all the news and updates from your payers, as many are making minute-by-minute changes to their beneficiaries' access to care. This is yet another reason that we absolutely must advocate at our individual state levels to ensure we are recognized as essential providers in line with recent guidance from the Department of Homeland Security. So, if you have downtime right now, focus there on advocacy. But the obvious immediate answer may be to utilize telehealth technology to treat patients, and we will address that in the second half of this webinar, so just sit tight. If you're on the other side of the staffing equation and you have either already experienced or are currently experiencing a drastic drop in patient volume and thus cash flow, we feel for you. There was truly no way we could have predicted this coming, especially not this fast. In the past, during planned major transitions like ICD-10, we've recommended having 3 to 6 months of cash on hand to cover those expenses. If you heeded that advice and kept those reserves stocked, then you and your employees will likely be able to weather the storm together. For now, if you have behind-the-scenes operational work or strategic work even for your team to do, consider focusing staff resources there. While we don't know how long this pandemic will last, and we know it can't last forever. As the eternal optimist, I believe that we must make lemonade out of lemons. So if you can, why not take this time to truly work on your business since you can't work in your business? You could effectively use this time to jumpstart on big improvement projects. Even better if your staff can do that work remotely to further diminish the risk of transmission. Think advocacy during this time as well. Now stay tuned to our WebPT blog, as I will be starting a series specifically on this topic very soon.
The best part about advocacy is while we are socially distancing ourselves and possibly sheltering in place, it's a good way to still connect with our colleagues and share all of our concerns and our ideas. So I like that idea, Heidi. Hospital workers across the country are undergoing disaster training and setting up overflow tents and mobile facilities to prepare for a hospital surge, especially in New York and California. And those hospitals are going to be at above normal capacity. So if you can lend a hand, if you happen to hold EMT or other emergency training, it would be a good time to lend your support in the front lines.
And on that topic of support, I'd be remiss not to suggest another opportunity where we can lend a hand, and that's checking on the elderly members of our communities, patients and non-patients alike. If you can, offer to collect or source food and supplies for those who are too high risk to be out and about right now. Effecting meaningful change in this time of crisis is going to take all of us working together.
Alternative services such as home visits and telehealth we'll cover more thoroughly in a bit, are also valuable options to support this population.
Now, if you don't have cash in reserve, then there might come a time when you must cut staff pay, furlough, or even lay off employees. This is never an easy decision to make, nor a conversation to have, and quite frankly, it's gut-wrenching. And yet, occasionally in business, it becomes necessary. After all, you must think about your long-term viability as a business. My best advice is to cope with the heartbreak and remind yourself of why you became a therapist in the first place and how many patients you have helped and will continue to help once the situation stabilizes. But that can only happen if you are able to reopen your doors once the dust settles. This is where your company culture will truly shine. Some examples of solutions are to have everyone on staff from top to bottom take a pay cut to enable all employees to sustain some level of pay in the interim, and/or to help ensure continued employee health benefits. Or furloughs may be necessary with the ability to rehire once services are needed again. This will allow employees to apply for unemployment in the interim period, but still feel some stability in knowing that you plan to rehire them once patients start returning. If that's not feasible and you need to lay off staff, be as supportive and empathetic as humanly possible when you explain the reality of the situation. These are unprecedented times, and making tough decisions and sharing tough news must be done with respect and empathy. After all, most of the world is scared right now, so be especially mindful of that.
You'll want to provide resources to help those staff members obtain unemployment benefits, and be aware that under most state laws, you'll need to compensate employees for any paid time off they accrued. In fact, before taking action that involves changing an employee's work status, I always recommend consulting with an attorney. And I know right now these may not be costs that you want to dole out, but it will help you save money and headaches later by making sure you are implementing the right layoff and furlough decisions legally.
Now, while updates are being provided daily, we're still waiting for details from the federal government about the broader COVID-19 economic stimulus package for individuals and businesses that Vita mentioned earlier. But we do know that disaster relief loans are available through the U.S. Small Business Administration, the SBA. If your practice is struggling to make ends meet during this pandemic, then you can apply for a low-interest long-term loan on the disaster loans page of the Small Business Administration website. Small businesses may borrow up to $2 million for economic injury. The SBA is also committed to assisting small businesses in accessing federal resources and navigating their preparedness plans. To learn more, visit the SBA website.
So on to communication. There is a lot of fear-mongering in the world right now, and it makes sense that most people, staff and patients alike, are seeking calm, level-headed discussions about actionable next steps. So as business leaders, we walk a fine line between making sure our people are well informed and taking proper precautions, being careful not to add fuel to the panic and the fear, especially when that fear and panic could extend to patients.
Now, one approach that I've found particularly effective when it comes to staff communication is to share details and thorough information with my leadership team, and then a one more high-level, positive yet transparent message to the rest of my staff. Right now, the two most important messages I'm sharing with my employees cover the precautions necessary to keep them safe and healthy, and the mission-critical information they need to do their jobs while working entirely remotely. Our leadership team, on the other hand, is receiving much more detailed and frequent updates about our operational plans to support our members over the next several months. We have established virtual war rooms consisting of members of all teams and departments to make sure we are all up to date on the latest developments.
And for you, the most important message to communicate with your staff involves frequent hand washing, staying home when someone feels sick, and social distancing as much as possible outside the clinic to ensure the safety of your employees, their families, and your patients. Communicate often with any updates that you have. Be straightforward and transparent while remaining calm and in control, and assure your team that you are doing everything you can to keep your doors open.
And when it comes to patient communication, I recommend taking a similar approach. Don't share with patients what's keeping you up at night. Instead, keep the messaging focused on the precautions you, as a trusted healthcare professional, are taking to keep them safe and their care accessible. Share your cleaning schedule and remind them of best practices you've implemented to keep their families safe.
Absolutely. I would make it a point to let patients know you are adhering to all CDC guidelines and offering alternative service delivery methods to serve them whenever possible.
Well, that's a great segue into our next topic, Vita. Let's talk about alternative services. If patients are unable to come to you for their essential care, considering going to them, either via home visits or telehealth services. Now, I'm going to pass the mic over to John Wallace, our resident billing expert.
Thanks, Heidi. Home visits can be especially effective in situations where it is essential to maintain care continuity. Per Medicare Part B and some commercial payer guidelines, outpatient physical therapy services or OT outpatient services can conduct and bill for home visits for those services. If you're in doubt about a particular payer's rules and billing guidelines, check your payer contracts or check with the payer directly. Even if you knew the answer 6 months ago, you may not know the answer today because payers are changing rules at unprecedented pace. As it stands, only about half the commercial payers allow for covered home visits under their plans. Many times home visits are not covered or they're covered under a separate plan. And just like in the clinic, you'll want to verify that Medicare patients are not concurrently receiving Medicare Part A services such as home health. Otherwise, you won't get paid for any Part B services.
And on that note, you'll also want to reach out to your liability insurance carrier and make sure coverage extends outside the clinic.
And while you still need to take every necessary precaution to keep yourself and your patients safe and healthy outside of the clinic, home-based care may be a safer option than having multiple patients and staff members in one building, especially if your patients are unable or unwilling to come to you. If you go this route, be sure your clinic's technology supports remote work. That means having an EMR and scheduling software you can access via a mobile device like a phone or tablet. You can also forward your office line to a mobile phone so patients can reach you to schedule their appointments while you're out of the office. In an ideal world, offering remote telehealth services would be one of the best ways for rehab therapists to ensure care continuity during a pandemic because it allows you to serve your patients by bypassing the health risk of meeting in person. Unfortunately, our telehealth situation is not ideal, and each payer and state has its own regulations and guidelines regarding telehealth. That means providing and getting paid for telehealth services is tricky, to say the least.
That is exactly right. And that's why if you do decide to offer remote services to your patients, you must confirm that telehealth falls under your scope of practice in your state. And if it does, then you can provide telehealth even if it's only on a cash pay basis.
Due to the nature of this crisis, the healthcare landscape, especially regarding remote patient management and telehealth, is changing very rapidly, and CMS and other payers are loosening telehealth restrictions on a day-to-day basis. But no one can predict exactly how regulations will change over the coming weeks, or how new payer policies will actually be implemented. This is why rehab therapists must monitor updates from the source. This includes payers and also your major government departments like CMS, commercial payers, and your professional organizations, whether that's APTA, AOTA, or ASHA. If after checking your state's Practice Act and the latest policy updates, you determine that you can legally provide telehealth, then you must decide what type of remote services you should provide and how are you going to provide them. There are 3 types of billable virtual care services: telehealth services, which encompass remote patient treatment, telephone visits, which encompass remote case management, and EVisits, which CMS described in the most recent final rule as non-face-to-face, patient-initiated digital communications that require a clinical decision-making that would typically have been provided in the office. Currently, due to a temporary provision, rehab therapists are allowed to bill Medicare for e-visits only. Some commercial payers are echoing this change. Aetna was the first major payer to do so, and a couple of regional Blue Cross Blue Shield offshoots followed closely behind. But this particular area is changing every hour, so it's important that you follow with your own unique payers what their policies are. Industry policies are changing so much, you must watch for these updates. If you have not subscribed to your major payers' websites, you should do so immediately. No one can track these changes for you. You should not look to APTA, AOTA, ASHA, or WebPT to be able to maintain all these threads at one time. It's up to you to call and verify the benefit with the payers in question.
Now, John, before we continue on this topic, I think it's very prudent to make sure that we clarify some of the lingo that we're going to be using as we talk about telehealth, because it can be very confusing. The word telehealth is now being used within the industry, and it's nebulous and all-encompassing. When we talk about telehealth, we're referencing any and all remote services that clinicians across the healthcare spectrum provide to their patients. Telemedicine is telehealth, and telerehab is telehealth. It's important that you don't mix up telehealth as a general concept with specific types of virtual care visits, like a telehealth visit, as John just explained, occurs when you remotely treat a patient providing TheraX virtually, for example. A telephone visit is when you remotely communicate with your patients and complete case assessments and management. And finally, the e-visit, which we just referenced, is when you complete an assessment and case management services and specifically bill Medicare or other payers that now allow rehab therapists to bill these codes. Keep in mind that Medicare doesn't actually consider these e-visits as telehealth by its standard definition, even though we are talking about them in the telehealth section of this webinar.
Thanks for that clarification, Heidi. There are 2 basic methods of administering telehealth. The first is real-time synchronous audio and video, and this occurs when you communicate with a patient in real time, like through a live video call. The second is asynchronous, which is when you communicate back and forth with a patient over a period of time, like by sending and receiving recorded video files or other information. Synchronous telehealth is the most common type of telehealth. Asynchronous telehealth is being phased out, except for secure texting platforms, which you'll hear more about later. However, both methods of telehealth administration are still acceptable at this time, so you can pick the method that works best for you or best for your patient, as long as you bill the appropriate CPT or HCPCS codes with the appropriate modifier. Once you decide which type of telehealth you will provide, you must select a telehealth software to use.
Now, normally you have to select a HIPAA-compliant telehealth platform that includes you conducting a comprehensive risk assessment before implementing that software. However, during this pandemic crisis, the Department of Health and Human Services Office for Civil Rights is giving providers a little bit of wiggle room. As of March 17th, for the duration of the nationwide public COVID-19 health emergency, OCR is exercising enforcement discretion for healthcare professionals who provide, and I'm quoting, good faith telehealth services to patients through everyday communication technologies. In other words, you won't have to conduct that entire comprehensive risk assessment up front when implementing your telehealth platform during this crisis, and that helps you get this alternative service off the ground. If you are considering good options, OCR specifically recommends platforms like Skype for Business, FaceTime, UpDocs, VC, Zoom for Healthcare, Doxy.me, or Google Hangouts. That being said, we highly recommend selecting a HIPAA-compliant platform that will enter into a HIPAA business associate agreement with you, even if you do that at a later date. A consumer-facing platform may fit the bill at this time, but patient privacy should still be your priority, even if it's not your first or second priority right now. And when you have an opportunity to vet your platforms through a comprehensive risk assessment, I recommend doing so.
Now, up until this point, PTs, OTs, and SLPs haven't had many opportunities to learn the ropes of compliant telehealth billing. So this next section might feel a little overwhelming as it's uncharted territory. Please remember that we will open up the floor for questions at the end of this webinar. We'll also send a recording of this webinar out to all registrants, and our team will create that FAQ with answers to all of the most commonly asked questions that we receive and send it to all of you after this presentation. I know that we can do this doing it together.
So when billing for remote services, you must document two site locations, the originating site and the distance site. The originating site is where your patient is located, and the distance site is where you are located. State licensure requirements still apply in telehealth situations, so before you start treating patients outside of your state, exercise caution and contact your state licensing board or consult a healthcare law expert first.
Finally, if you're billing CPT codes for telehealth visits, make sure to designate the place of service, or POS, as 02. However, if you're billing one of Medicare's EVisit codes, more on those in a moment, then you'll want to use 11 for your POS to indicate that you're providing the service from an office, or 12 to indicate that you're providing the service from your home. POS 11 and 12 also apply to telephone visits.
So there are 4 telehealth modifiers that therapists should acquaint themselves with before billing for telehealth services and e-visits. It's critical that therapists understand how these modifiers differ because each one only applies in certain situations. In other words, you cannot affix a telehealth modifier to any CPT code and bill it as a telehealth service. You must be more thoughtful and make sure that you're always following telehealth compliance protocol. That means using specific telehealth CPT or EVisit HCPCS codes and affixing the correct modifiers as they are required. So the first modifier we want to talk about is modifier 95. Use this modifier when you administer real-time synchronous services for the telephone CPT codes. Just to be clear, the CMS EVisit codes do not require the 95 modifier. The second telehealth modifier is the GT modifier. It is also used to indicate that you provided real-time synchronous services. However, Modifier 95 replaced the GT modifier in 2017. And while you can still technically bill the GT modifier in certain instances, Modifier 95 will likely be the more appropriate choice. Your commercial plans do continue to use the GT modifier for covered telehealth services in some cases, so you should check in with your individual payer policies to determine which modifier they prefer to use. The third telehealth modifier is the GQ modifier. It indicates that services were delivered asynchronously. As I mentioned earlier, asynchronous telehealth is slowly getting phased out, except for only a very limited number of applications, which means GQ an old, albeit functional modifier. So the final modifier is the CR modifier. It indicates that services are due to a catastrophe or disaster related per a formal 1135 waiver issued by CMS, and this was done for COVID-19. It's also been used a number of times in areas where we've had devastating hurricanes and fires. Some of you may not have been exposed to that before. Rehab therapists must use this modifier when billing the E-codes for Medicare that Medicare recently made available to rehab therapists, and regardless of whether the services are delivered synchronously or asynchronously. Use of the CR modifier means that you know that you are utilizing services that were approved subsequent to the disaster waiver. PTs, OTs, and speech and language pathologists must bill very specific CPT codes for covered telehealth services. The first set of these codes are called telephone services. Providers can bill these CPT codes when they provide non-face-to-face assessment and management services to an established patient, parent, or guardian. These codes are available only when billing some commercial or workers' compensation payers that are not following CMS guidelines for remote services. Additionally, these remote services, when billed, cannot be closely related to other assessment and management services that occurred either during the prior 7 days or that will occur within 24 hours or during the second soonest available appointment.
These codes are further separated by the time you spend on the service. Providers should bill 98966 for 5 to 10 minutes of medical discussion, 98967 for 11 to 20 minutes, and 98968 for 21 to 30 minutes.
Telephone visit codes also come packaged with a lot of rules. There are many scenarios where you should not bill these CPT codes. For example, providers cannot bill these codes more than once during a 7-day period per patient. The same month they bill codes 99478 through 99489, and at the same time they bill codes 99495 or 99496, or in conjunction with CPT codes 93792 or 93793. Just to emphasize this again, rehab therapists should not bill these codes to Medicare. CMS has its own set of EVisit assessment and management codes that rehab therapists should be using. And along the same vein, you should also check in with individual commercial payers to see which codes they cover. I know that's a lot of information to digest, so please keep in mind we will email out the recording and the slides to all registrants. And John wrote a comprehensive telehealth billing article for the WebPT blog, so you can access this information there too.
Let me add that while private practice therapists would not be using these 99 codes or the 93 codes that Vita mentioned, if you work subsequent to a physician seeing a patient in your practice or in the hospital that day, these limitations would apply to your services. So the second set of telehealth CPT codes that rehab therapists can bill to commercial and workers' comp payers are the online digital E&M services. Healthcare workers bill these codes when they provide patient-initiated remote services that require evaluation and decision-making. When calculating minutes for these codes, providers should count up all the cumulative time over a 7-day period that they dedicated toward. So reviewing the initial patient inquiry, assessing the patient's problem, interacting with other healthcare professionals regarding the problem, developing management plans, and then communicating that to the patient.
Like the previous set of codes, these codes are separated by the amount of time a provider spends on the service. So providers should bill 98970 for 5 to 10 minutes of evaluation and management, 98971 for 11 to 20 minutes, and 98972 for 21 or more minutes.
Rehab therapists also need to watch out for and avoid some particular scenarios that may come up when billing the online digital E&M codes. Rehab therapists cannot bill these codes when conducting non-E&M communications, like when scheduling appointments or sharing non-evaluative test results. Rehab therapists also cannot bill these codes more than once during a 7-day period per patient. For home or outpatient monitoring, if they are also billing 93792 or 93793, or work in a clinic or a hospital where that's being done, or when billing one of the 13 codes listed on the slide. And like with the previous set of codes, rehab therapists should not bill these codes to Medicare. Further, you should always check in with your other commercial and workers' comp payers before you bill these codes to see if they will be covered at all.
On March 17, 2020, CMS released an emergency policy update that relaxed its telehealth requirements and announced that it would reimburse PTs, OTs, and SLPs for virtual services that occurred on March 6th or later. Many commercial payers have adopted Medicare Part B policy in the past, and they may choose to follow CMS's lead in this regard too. Some, as John mentioned earlier, already have.
That's right. For now, all we can do is familiarize ourselves with these codes so that we can ensure that we're using them correctly. To start, rehab therapists are supposed to bill these codes when they provide online assessment and management services to an established patient for up to 7 days. And to clarify, an established patient is a patient who has previously treated in your office. Please note that you can use these codes to see an established patient for a new problem that you have not seen yet in your office. Like online digital E&M services, the minutes for these codes are counted cumulative throughout a 7-day period and are billed differently depending on how much billable time you accrue. Rehab therapists should bill G2061 for 5 to 10 minutes of assessment and management time, G2062 for 11 to 20 minutes, and for over 21 minutes, bill G2063. Remember, when you bill these codes during the COVID-19 response, you must use the place of service 11 or 12, depending on the location of the therapist. Were they in the office or were they in their home, as well as the CR modifier. Now, all of these different groups of codes can be confusing, so here's another way to think about it. The digital E&M CPT codes that we talked about earlier, that's codes 98970 and 98972, are the CPT equivalents of the CMS HCPT codes for the EVisits. That is the code you see on the slide, G2061 through G2063. So in qualifying scenarios, use the HCPCS EVisit codes, that's the G codes, to bill Medicare and any other payers following CMS policy. Use the digital E&M CPT codes 98970 through 72 to bill commercial payers and workers' compensation payers that are not using the CMS HCPCS codes.
Another thing to remember is that these EVisit service codes have no geographic or location restrictions, so that means they're not limited to rural settings. Anyone can use them.
And like other codes we've discussed thus far, there are certain scenarios during which you should not bill these codes. Don't bill them if you do not have an established relationship with the patient, or bill them more than once in a 7-day period, or if the encounter was not patient-initiated. Now, even though patients must initiate these encounters, you're not prohibited from advertising or mentioning these services to your patients. So if you can, it might behoove you to reach out to your patients and encourage them to contact you to talk about and assess their current care plans.
So on one hand, I'm glad that CMS elected to relax its remote care policies. This change, no matter how small, was still a very positive one, and I'd rather trend positive than to see no changes at all. But on the other hand, we need to acknowledge that these codes are not for telehealth treatment services. EVisits deal with case management, not specifically treatment. Despite CMS's changes to healthcare policy, PTs, OTs, and SLPs are still not considered official telehealth providers under Medicare. That's why I believe that this is a very important time for us to be active and vocal advocates for telehealth. We have a couple different opportunities to advocate for ourselves in the coming weeks. The first is very PT specific. Right now, the private practice section, PPS, of the American Physical Therapy Association is organizing an effort to encourage lawmakers to pass telehealth legislation that would allow PTs to meet our patients' current and immediate needs and mitigate some of the revenue losses that we face. I know we have a lot on our minds right now, but if you're a PT, I strongly urge you to support PPS's advocacy efforts, even if you're not an APTA member. The second advocacy opportunity I'd like to mention applies to PTs, OTs, and SLPs alike. We all need to come together and support the Creating Opportunities Now for Necessary and Effective Care Technologies Connect for Health Act. It's HR 4932 or S.2741. This bipartisan legislation would expand the use of telehealth services and ease restrictions on telehealth coverage under the Medicare program. Please contact your legislators in the House and Senate to ask them to support this bill and waive the telehealth restrictions that apply to all rehab therapists, PT, OT, and speech under Medicare. Successfully getting rehab therapists classified as full-fledged telehealth providers could mean the difference between clinics staying open or definitely shutting their doors. Be sure to check out my pandemic and PT post on the WebPT blog for more information on how to join this effort.
Thanks, Heidi. I'd like to add one thing just as an aside here. Everything that we're giving to you and that you're reading wherever you're reading it about billing for these services has all come up in the last 7 days. So I can tell you that in the world of WebPT, we have sent out some of these claims and we're now just starting to see some claims come back. So you should be aware there may be changes in some of the guidance we've given you on how to bill based on how the remittance advice and explanations of benefit actually come back. But at this time, it's possible to receive payment for telehealth services. However, you will often need to look to the patient to foot the bill for the care that they need. As we've already discussed, payers are starting to adjust their coverage policies in light of COVID-19. Some commercial payers, Medicaid programs, worker compensation payers already pay for rehab teleservices to some degree, and others have begun to follow suit. It is impossible to say which payers will end up changing their policies or how they'll change them, but I think it's safe to say that we'll see more payers roll out policy updates in the coming weeks. After all, we've already seen Aetna relax its policies, and we're expecting to see similar actions from many of the Blue affiliates, Cigna, and United Healthcare. But again, we want to emphasize that Medicare will not pay for rehabilitative therapy telehealth. It will only pay for the aforementioned EVisit services. But I'd like to say that there is hope because CMS is rolling out new policy updates at a rapid rate, so this could potentially change. we certainly hope that it does.
And in many cases, even if the payer won't reimburse you for telehealth, you can deliver and collect cash payment directly from the patient. Specifically, you can do it if a service is not covered by the payer for which you are a preferred provider, or if you are not a payer's preferred provider at all. And of course, you must treat in accordance with your State Practice Act at all times. But even if you do decide to provide telehealth services on a cash pay basis, you can't necessarily bypass the payer altogether. You may still have to bill the payer so it can assess the patient's liability, and many payer contracts contain clauses that require you to bill all services to the payer, even if you don't know if they would cover them. So be sure to confirm what is required of you before collecting payment directly from a patient. When it comes to providing Medicare cash pay telehealth, follow the standard Advance Beneficiary Notice of Non-Coverage ABN procedure.
And just a word of warning, there's one situation that definitely can prevent you from collecting cash payments from patients. If a payer's medical policy classifies telehealth services as not medically necessary or says that its effectiveness is not established, then you cannot balance bill the patient. If you do end up charging the patient and sending the bill to the payer, then it will assign the balance to the clinic or to the therapist who provided the services. So we can't emphasize enough, as John said earlier, it is your responsibility to stay updated with all of your payer policies, as well as your State Practice Act, to understand fully on how to implement telehealth clinic services.
And while we're on the subject of payment, if you would like to help out any patient who is under financial strain at this time, you may do so because the Office of Inspector General, that's the Department of Health and Human Services Office of Inspector General, announced on March 17, 2020, that providers could voluntarily, temporarily elect to waive cost sharing like copays and coinsurance without sanction or penalty. Typically, doing so, routinely waiving cost sharing could result in audits, sanctions, or penalties, but not so during this time. This is voluntary. It's not something you have to do, but it is an option for you.
And I know things are evolving rapidly, and it's left many of you feeling anxious about what lies ahead. But no matter what the future holds, my team and I will continue to communicate and offer guidance every step of the way. It's my sincere hope that this information helps you feel more prepared to make the best, most informed decisions for your practice and take on whatever challenges we might face. As a final note, don't forget to take care of yourself during this time too. I think it's as inherent caregivers, therapists tend to focus our attention on making things better for everyone else, and it becomes all too easy to let our own needs fall to the wayside. But right now, your team needs you at your best, and so do your patients. So be kind to yourself, take care of yourself, and remember, you are not in this alone.
You are right, Heidi. No one is in this alone, and that's why we're now going to tackle as many of your questions as we possibly can. And oh my word, we have so many. So let's jump into it. John, this question is for you. And I know you hit on this during the presentation, but we are seeing this question a lot. Can I ever bill normal therapy codes like the 9700 codes as telehealth?
I'm only aware of a few payers on the East Coast who are allowing that. You definitely cannot do it to Medicare based on Medicare's recent information. And most payers that are adopting telehealth rules are not allowing direct personal contact face-to-face codes to be billed as telehealth, since those two things would be mutually exclusive.
Thank you, John.
And just as a side note on that as well, in order to bill, you have to be able to practice telehealth. And so please check your state practice acts. I know here in Arizona, we are in the midst of pushing legislation to help get rehab therapists named to the telehealth policy to relax our ability to complete telehealth during this time. So please make sure you're following your state practice acts before you even attempt to do telehealth within your clinics to make sure that you legally can perform those services.
Let me add that you shouldn't rely on the payers to check your practice act before they may lead you to the conclusion that you can provide telehealth services when you really can't.
Okay, thank you, John. So another question that is coming in frequently is how all of this applies to pediatric therapists and school-based therapists. As we know, there are millions of children not in school right now, and many of those children would be receiving in-school care. So we have a lot of peds therapists on, and they're really curious how this all applies to them.
Okay, so let me break that big group up into two different groups. So the school-based and school paid-for services are a little bit easier to address. You should check with whoever the medical director is or whoever the program coordinator is to find out how they want you to deal with remote patient management. And I think that's the best thing for you to do. At that point, if they say yes, and that's all they say, then I would build a CPT code EVisits. If they say yes, but we want you to use the CMS guidance on EVisits, then you would use the EVisit G codes. Now, for pediatric patients who are covered by commercial payers, the rules are not any different than they are for the adults, and you would follow all the rules that we discussed here today. So you need to check with the payer to see if they have a relaxed telehealth policy and how they would like those services billed to them.
And then I also just want to jump in and add that some Medicaid programs did cover telehealth previously, and those would be covered for some of your pediatric patients. So you should check your Medicaid policy because that will define what codes to bill and how you can use telehealth. And some Medicaid programs like Arizona are considering expanding out telehealth coverage. So check with those programs and they will give you more specific guidelines.
Thanks for bringing that up, Vita. So but prior to COVID, there were 21 states Medicaid programs paid for telehealth services already. And I'm aware of at least 11 more states that have been granted waivers to beef up their Medicaid programs within their states. So well over half of the Medicaid programs will cover telehealth services. You may have to reach out or check the website of those payers or those state agencies to find out how they want those services presented.
Awesome, thank you. So we have a handful of questions around telehealth services and telehealth within WebPT. So I'll rapid fire some information and then I'll have Heidi jump into specifics about telehealth within WebPT. So in terms of recommended video platforms that you can leverage for telehealth, as Vita talked about during the presentation, there are looser restrictions right now on what you can use. So you can use things like FaceTime and Google Hangouts, Skype for Business. However, those aren't solutions that are going to see you through long term. I imagine as everybody is exploring this virtual world, there are going to be things that stick after this is all said and done. So it would benefit your practice immensely if you went with a telehealth video solution that will sign a BAA and is HIPAA compliant. And so on that note, we recommend Rapid Response from Bluestream and Doxy.me. Both offer free versions. So explore those. Additionally, with WebPT, our HEP is completely equipped to facilitate the Medicare-covered e-visits. So you are allowed to communicate to your patients that your HEP solution can be leveraged for assessment and management services, these e-visits. The patients have to initiate the communication, so encourage patients to download the Strive Hub app. That's the patient-facing mobile app for our HEP software. Through the Strive Hub app, patients can initiate communication with you, and that is all through secure messaging. So once you receive that patient-initiated communication, you can then perform case management, assessment, and case management services. So you can talk back and forth with the patient, you can update their plan of care, you can update their home exercise program, and then you can push that updated home exercise program back to the patient so that they can progress in their care. And all of that suffices as an EVisit. So right now, we understand how imperative having an HEP is, and that's why we are offering all of our members 2 months free of HEP. We're actually going to chat out a link right now. If you're interested in signing up for our HEP and getting the first 2 months free, you can submit your information through this form that we're chatting out to you. If you're not a member, you may sign up for WebPT and we will give you the HEP free. We're also offering specials on setup costs. So this is a tool for everybody to leverage, and it can help you facilitate communication with all your patients. But with Medicare specifically, you can use the HEP to satisfy those EVisit requirements. And now I'll let Heidi specifically talk about how you document telehealth, and she can hit on how you do that in WebPT as well.
So first, from a documentation perspective, let's tackle the e-visits. There are very specific requirements that John mentioned earlier. This has to be an established patient, and that this visit was patient initiated. So making sure that you are documenting that in your subjective portion of your SOAP note will be imperative to validate that you have met the requirements to complete an e-visit. Also, that you are able to only bill an e-visit once during a 7-day period. So patients can only be seen through this manner once a week. And you do not have to have an in-person visit in between these. You can only just do these e-visits once a week. So with regard to billing within WebPT, currently you can enter the codes that we mentioned, the G codes or the CPT codes, depending on the services that you're providing, can be done through the custom code section. We are currently actually adding the G codes into the platform, and you should be seeing those as available codes very shortly. So stay tuned for that, to where you can actually just check the codes if it, based on appropriate time that you provided the e-visit for the patient. So currently, adding those G codes into the custom code fields is your best bet on making sure that you get those codes into your billing software. And so we also have the ability to then bill for those codes, whether you're utilizing our TheraBill platform or WebPT billing through RevFlow or any of our RCM services.
Thank you. And while we're on the topic of e-visits, we have seen questions. John, do the e-visits apply toward a patient's therapy cap?
I haven't seen that discussed specifically, but we don't add the GO or GP or GN modifiers to those services. So I would say that they do not count towards the cap, but as I said, no one has specifically addressed that at the CMS level.
And would an e-visit count as a visit, say if you're with a payer where you still are doing functional limitation reporting, or if you're filling out a progress note per a certain number of visit counts, would an e-visit count as a visit count?
So these are not therapy always or therapy sometimes code, which is a Medicare designation for services that are offered through a properly executed plan of care. So no, it wouldn't count.
Great. If you conduct a video visit with a patient, can you count all of that time toward the eVisit G codes? I feel like this is a trick question because it has the word video visit in it. So e-visits are not video visits. John, I don't know if you want to elaborate that on a bit more.
Yeah, so if you're using video, then you should be using video and audio. I don't know if you meant that included when you use the word video, but it should be through a non-public, accessible, or public-facing platform. So the current rules, because of the issuance of the waiver, would allow you to use FaceTime, and you can count that time, but there's the services that you have to document to successfully get paid for these e-visits is that the patient has a concern, a question, a change in function, has something that they're trying to deal with. You assess what they're saying to you about that, demonstrate your clinical reasoning in the note, how you're going to help the patient manage it, and then what the go-forward plan is with the patient. So those are the things you've really got to document in order to count that time towards the e-visit code. So I can tell you that in a number of the policies I've looked at where the e-visits are covered, either the CPT flavor or the HCPCS flavor, they say this is not an opportunity to do physical therapy over the phone, not necessarily therapeutic exercise or therapeutic activities, but to help a patient work through managing their care at home.
That is a very important point in defining what we're able to do right now. I think there's a lot of questions around whether or not you're able to complete an initial evaluation, progress note, reevaluation. This is not the way to be able to do that. This is truly assessment and management of helping patients get through this difficult time in which they may not be able to access you personally or in person. So critical value there, John, in defining that. And just as a caveat, I think that, again, we're in unprecedented times. These are very important times for advocacy as we move forward. In advocacy for telehealth, it's going to be really important that we truly define moving forward, because I think that, as I'm sure many of you are experiencing, there are people who are taking this opportunity, this moment in time, to be opportunistic in trying to leverage platforms that may not necessarily actually meet the compliance standards that they're going to be required moving forward. So be careful, find ways to help your patients at this point in time, but please, reference sites that are reputable and that are truly, giving you information that is based on reputable sites.
Awesome. Thank you. Okay, so another question that has come up a lot is what suggestions do we have for therapy assistance at this time, as they can't provide telehealth services?
So I can jump in.
That's a tough question. Go ahead, Vita.
I was just going to say, if it's telehealth services, it's based on the state and the payer. And some states do allow assistance to provide telehealth, and some payers also allow assistance to provide telehealth. So don't assume for telehealth, not e-visits, that the assistant is not qualified as an authorized provider. And John, I'll pass it over to you to add to that.
So I think the really critical question about assistance is they've got to be operating within their legal scope of practice. So, and actually the scope of practice for assessment is slightly different between PT assistants and OT assistants. So, you in an office setting, you can use a PT assistant to take measurements. They can, assess whether a patient is doing something safely. So those things are within their scope of practice. But, a one-on-one e-visit between a PT assistant and a patient would be unlikely to pass scrutiny because when the patient presents you with the problem, is it within the assistant's scope of practice to assess that problem or not. And it's no different whether that occurs over the phone, over a secure telehealth platform, or in your office, right? You can't have an assistant complete an evaluation or a reevaluation, and you can't do that via telehealth either.
And then, John, can you quickly clarify what constitutes as an established patient? As we saw with EVisits, the patient has to be established. So what does that mean exactly?
Well, I don't know if I can answer it quickly, but I'll try. If you use the physician E&M services definitions of new patient and established patient, once you have seen a patient in your practice, they are an established patient. So you could see a patient that you saw 6 months ago who presents with a new problem. Now, that is a more liberal interpretation than was APTA's interpretation on their presentation last week. But CMS has not given a definition of established patient. But I think for our purposes, the definitions in the CPT manual are sufficient because there are no definitions of new or established patient for rehab services in the CMS online manuals.
Great. Okay. We are at time. So as a reminder, if we didn't get to your question today, not to worry. We were combing over all the comments on Facebook Live. We're combing over all the questions that came in through our webinar provider. We are going to compile all the most frequently asked questions and form it into a blog post that we're going to share with everybody. We're going to send out this recording today along with the slide deck. And the blog post, once that's live, the FAQ, we'll share that as well. Additionally, we're not done with communicating with all of you. We are currently mapping out ways in which we can continue to host live Q&As and additional webinars to ensure that we are always keeping you informed on all of this rapidly changing information. Your best bet, though, is to follow us on all the sites that you see listed here and make sure that you're following the WebPT blog. If you subscribe to it, you can get the blog post that we publish emailed to you every week. That way, as this situation evolves and changes, you're always up to date on what's going on. And also, to just echo John's sentiment, make sure you are contacting all your payers and verifying everything in your state practice acts. It's imperative that we are all together doing our due diligence to verify all of these changes and making sure that we are appropriately applying them to our practices. I cannot thank you all enough for joining us for our largest webinar ever. It was certainly beefy and we covered a lot, but definitely hit us up on any of these channels to ask additional questions or just chat with us. We're here for you and we're going to see you through this storm. John, Heidi, and Vita, I thank you so much for all your expertise. It was amazing having you on today.
Well, thank you, Shar, and thank you to our amazing team who helped put together all of this information for us and also to present to all of you today. We have an incredible team just combing through so many different sites, finding the most updated information. And for all of you out there, we will get through this. And to be honest, on just like 9/11 and other major incidents that have happened throughout history, I believe that we will come out slightly different on the other side. But this is your time to really assess what that different can look like and be prepared and start preparing now to get ready to when we do come back into full force to be even better than we were before. Thanks, everyone. Thanks, John. Thanks, Vita.
Thank you, everyone. Have an awesome day.